Hello and welcome to this discussion on quality of care in tuberculosis. But really, I think I had a small lag. I'm a public health specialist and writer, and I work with communities both in TB, HIV, but also in mental. In both, we're going to try and make this discussion bilingual. हम इस discussion को bilingual रखने की कोशिश करेंगे. हम अपने सारे पैनलिस्ट से अंग्रेजी और हिंदी दोनों में सवाल करेंगे ताकि ज़्यादा से ज़्यादा लोग इस डिस्कशन से जुड़ सकें. सबसे पहले हमारे पैनल का इंट्रोडक्शन. हमारे साथ हैं जो डॉक्टर जय मुलेरपट्टन, जो हिंदुजा हॉस्पिटल से हैं और बहुत वेल नोन क्लिनिशियन हैं, और उनको काफ़ी एक्सपीरियंस है प्राइवेट सेक्टर में ट्यूबरकुलोसिस एंड लंग डिजीज़ को एड्रेस करने का, और उन्होंने कई सैकड़ों पेशेंट्स को का उपचार किया है. और मेरे साथ जुड़े हैं आशना आशेष, जो एक बहुत ही वेल नोन टीबी एडवोकेट हैं, राइटर भी हैं, लॉयर भी हैं, और पब्लिक पॉलिसी में काफ़ी काम करती हैं, और ये WHO STF की को चेयर भी रह चुकी हैं. फाइनली मेरे साथ हैं अक्षता आचार्य, जो कि एक वेल नोन टीबी एडवोकेट हैं, राइटर हैं. इन्होंने अपनी टीबी जर्नी पे एक किताब भी लिखी है, और ये एक थिएटर आर्टिस्ट भी हैं. तो वेलकम टू ऑल आवर पैनलिस्ट. हमारे पैनलिस्ट का बहुत बहुत अभिनंदन, आप लोग हमसे जुड़े. सबसे है कि क्वालिटी ऑफ केयर होता क्या है, और हम इसके बारे में बात भी क्यों करना चाहते हैं. Why do we want to discuss it? Because quality of care actually defines not just the experience of care individual, but sometimes it's the experience of care for the whole family or the whole community, in terms of the fact that if a doctor or in a health system, a doctor does not actively, or a health worker is unable to deliver the quality of care that we need, how do we experience our disease? And it is not just about how people speak to you, or how people give you medicines, or how your diagnosis is managed, but it's really about right from the symptoms. What information do you have? आपके पास क्या जानकारी है? आप किस तरह उस डिजीज के बारे में या उस बीमारी के बारे में सोचते हैं? बाकी लोग उस डिजीज के बारे में क्या धारणा रखते हैं? राइट अप टू जब आप हेल्थ सिस्टम में पहुंचते हैं, तो आपको किस तरह ट्रीट किया जाता है, और जब आपका उपचार होता है, when you're being treated, how are you being dealt with then? Also, quality of care really also refers to कि क्या ये सिर्फ जांच और इलाज की प्रणाली है? Is it only diagnosis and pure system, or is it more? Because क्वालिटी ऑफ केयर में बहुत सी और चीज़ें आती हैं, जेंडर आता है, आप ये सब बहुत ज़रूरी हो जाता है. तो इसी कारण से हम इस सब के बारे में बात करेंगे. सबसे पहले मैं आशा इस लंबी तामील बाँधने के बाद मैं आपके पास ही आ रहा हूँ, क्योंकि लोग बहुत सी चीज़ें बोलते हैं, मगर यू treated in both the health systems, public and private in a way, right? तो आपके हिसाब से ये जो हम हाई क्वालिटी केयर की बात करते हैं इन इंडियाज कॉन्टेक्स्ट पर्टिकुलरली बिकॉज देखिए वेस्ट में हाई क्वालिटी केयर और यहाँ पर हमारी अपनी रिस्ट्रिक्शंस हैं वी हैव आवर ओन लिमिटेशन सो व्हाट डज इट मीन टू यू टुडे आई मीन लाइक how you're a TB survivor you're also a representative of communities in India but also internationally.
थैंक यू चपल। जैसा कि आपने कहा इंडियन कॉन्टेक्स्ट में हाई क्वालिटी केयर का क्या मतलब है। आई थिंक very often we tend to loosen a binary. Either we say that we have advanced a lot and things are really changing, or we tend to reduce it to it's just diagnosis and testing. But in country as diverse as India, जहाँ पे लोग अलग अलग तरीके के होते हैं, उनके हेल्थ नीड्स अलग अलग होते हैं, आई थिंक द फर्स्ट थिंग दैट नीड्स टू कम इन क्वालिटी ऑफ केयर इज़ दैट इंक्लूसिविटी और कल्चरली कॉम्पिटेंट केयर होनी चाहिए। जो वो शिफ्ट आ रहा है धीरे धीरे, पर आज भी हम एक वन साइज फिट्स ऑल अप्रोच सिस्टमैटिकली, और ये किसी एक इंसान की गलती नहीं है, पर सिस्टमैटिकली हम वो अप्रोच रखते हैं काफ़ी। यू नो वेर से कुछ इतना भी सिंपल हो कि जैसे कोई न्यू रेजिमेंट का ट्रायल कहीं और हो, इट वर्क वेल फॉर अ लिमिटेड कोहॉर्ट इन पॉपुलेशन, बिफोर ब्रिंगिंग दैट हियर हमें ये देखना पड़ेगा कि यहाँ के डाइवर्स कंडीशंस में, यहाँ अलग अलग पॉपुलेशंस में, मल्टीपल पॉपुलेशंस में, what would that translate into, how effective would that care be? So something and this is both from the technical side of it or from the lived experience side of it. पर काफ़ी बार ये होता नहीं है, हम एक तरीके से वन साइज फिट्स ऑल अप्रोच में बैठ के रह जाते हैं, जहाँ डायग्नोसिस मिल गया, आपको ट्रीटमेंट मिल गई, तो अब आपको और क्या चाहिए। और मैं समझती हूँ कि एक प्रैग्मेटिक रिसोर्स कंस्ट्रेंट सेटिंग में यही मिल जाए तो काफ़ी बड़ी बात है। बट फ्रॉम अ राइट स्पेस पर्सपेक्टिव और पर्सन सेंटर्ड पर्सपेक्टिव, दैट कांट बी वेयर वी स्टॉप, दैट हैज़ टू बी आर मिनिमम, एंड देन वी हैव टू बिल्ड अबाउट दैट। थैंक यू।
No, thank you, Ashna. These are very good points. ये बहुत अच्छे points हैं कि क्या restraints हैं, क्या जब हम देखते हैं राइट बेस्ड फ्रेमवर्क की तरह के पर्सपेक्टिव से, या हम देखते हैं जब हम पर्सन सेंटर्ड की बात करते हैं, पर्सन सेंटर्ड की बहुत बात चली हुई है नेशनली इंटरनेशनली, सब लोग पर्सन सेंटर्ड केयर प्रोवाइड करना चाहते हैं, सब लोग उसकी कोशिश में जुटे हुए हैं। वो पर्सन सेंटर्ड केयर क्या है, उसमें पर्सन की क्या डेफिनेशन है, ये बहुत कम लोग पूछ पाते हैं। बट एक्चुअली आई वांट टू टेक सम ऑफ योर पॉइंट्स टू जय। जय, आप डिलीवर करते हैं केयर इन द private sector in one of the biggest and busiest hospitals in Mumbai. It is in many ways हर तरह का टीबी, हर तरह की लंग चेस्ट डिजीज, हर तरह की बीमारी आपके सामने प्रेजेंट होती है और आपका स्टाफ पूरी कोशिश करता है, but there are constraints as there are constraints everywhere in the public or the private sector. So I want to Jay, can you hear me?
Yeah, now I can. Can you repeat your question? I think
Yeah,
you.
sure. What are the biggest barriers in your understanding to deliver high quality care?
One is access, of course, to the patients. I mean, when they, of course, they come to Hinduja, you can get most tests done here, and thankfully um, we have an MOU with the RNTCP, so we do have access to bedaquiline, etc. But other drugs, they are very often forced to buy from outside, or they need to go to another RNTCP center and get things from there. So that's one thing. And of course, if you want to continue seeing the doctor here at a private center, and if you're staying far away, you might need to have to travel all the way here. So those things are there for patients who are very often sick, and इसलिए वहाँ एक तो डॉक्टर तक पहुँचना, और फिर जो भी टेस्ट है, दवाई है, उसके लिए जो एक्सेस होना चाहिए, वो इट्स नॉट ऑलवेज इजी और अफोर्डेबल फॉर पेशेंट्स, एंड probably the biggest barriers in the private sector right now. Hello? I think you've muted yourself. I think Chapal, you've muted
Sorry,
yourself.
sorry.
Yeah.
Technology is not my strong point. I think this is an interesting set of points that you have raised. Also, because as far as I know, your hospital is amongst the more efficient, the most more reliable hospitals in the country,
Yeah.
and there are obvious challenges that emerge even there because access, affordability, सब कुछ है जो
Yeah.
and of course there is the obvious problem of staff. How much staff can you have to deal with every patient, every affected individual and their families, to provide them the right guidance, support, and things like that. But Akshata, like Jay was saying, there are all these constraints. You were treated actually not too long ago, and what were your challenges? What, according to you, would be truly person-centered care that you should have got? If you can tell us briefly, which you did not get in a way. I mean, you were treated
Sorry, Chapal, can you repeat your question because your voice was breaking in between? I'm so sorry.
Akshata, can you hear me?
Yeah, now I can.
No, I was just saying, what is truly person-centered care to you as a TB survivor and also someone who advocates for communities? You have a long experience now in doing that.
Absolutely. Somebody who has recently been through that experience, I mean, the experience is quite fresh. So, and also last year I happened to write a paper on that. Not a paper, actually, a fellowship, actually. So, I think for me now, in hindsight, when I look back, I feel that the whole focus currently is, as you rightly mentioned at the beginning of our discussion, is just killing the disease. However, I feel that when we talk about care, it is not just about killing the bacteria, as opposed to it should be like, healing the entire person. And that demands us, like what we, I think, as patients would really, really appreciate is not just looking at the physical aspect of the treatment, but also emotional, social, and mental health aspect of the entire, because we go, I mean, when you're going through a treatment which is that lengthy, which can go up to 2 years or more than 2 years sometimes, just looking at one aspect is very, very narrow, and it's a very micro approach, in my opinion, because other than your physical health, I think these are the other aspects which are also affected as you go through, and taking care of that aspect is extremely important to ensure that once you are through with the disease, it's easier for you to integrate back into the society. That is one point which, in my opinion, should be included in the high quality care. And second is post TB care is also very, very important, in my opinion, because literally 2 days ago, a girl slid into my DM saying that it's been 2 months since she has finished her treatment, but still her appetite is not back on track. The neuropathy pain, it's still, there's a shooting pain in her feet. When will I get back to normal is what she was asking me, and I absolutely had no answer, because as Ashna rightly mentioned, there's no one size fits all approach. I mean, currently it's a one size fits all approach. So where are we looking? What as we as patients should there's a big question right in front of us once we're done finishing the treatment. What's next? So I think that all these two approaches that I mentioned is looking at the holistic approach, which includes physical, emotional, mental health as well. And once that is done, looking at the post TB care. So I think these are the two broader aspects which I would like to shed light upon.
I think these are all very valuable and important aspects. One of the things that I did want to also take to you, Ashna, and I'll also take it to Jay, what are the metrics by which we measure quality of care? Are the current metrics okay? Because metrics is such a tricky issue. Everybody thinks that they are providing good quality care, at least the best that they can. And so, how do we? Are the metrics currently okay in experiencing and understanding what are the needs of TB affected individuals?
Thank you Chapal. So I'm going to answer that with a personal story first. This is when I was on treatment for DRTB. And this was towards almost the fag end of my treatment, where because of the side effects, I had like huge debilitating mental health challenges, and I called my doctor one day. And I think, Chapal, you know the story, but it's very emblematic of what high quality care should have as a metric. So I'm going to start there. Um, so I'd called my doctor, and I thought I was making sense, but I was basically in a complete breakdown and trying to talk to him and tell him that I cannot basically take this anymore. And he told me something that shocked me right out, because he's like, you're going to stop your meds for 3 days. And I was like, क्या आप होश में हैं? मतलब टीबी की दवाई कैसे रोक सकते हैं? So, and he said something to me that stuck with me, because he's like, you're not happy. And again, for a second, I'm like, what does that have to do with anything? This is treatment. And this is someone who works in public health, right? Even for me, that thing is so internalized that दवाई लो और ठीक हो, and that's it. And he's like, you're not happy. We're doing all of this so that you can live well. And currently that's not happening. So under supervision, and I do not endorse this at all, under clinical supervision, for a few days I stopped my meds, and then I resumed them exactly how the doctor prescribed. This is very, very important. And those 3 4 days actually gave me the strength to sort of go on and complete my treatment and have a shot at a life where I actually get to work in TV now. But that my happiness was a metric, this even I didn't think back then. It took somebody kind and very, very qualified in providing quality care, um, to sort of get me to realize that, and then that informed my work. On a cognitive level, we sort of all know this, but we've internalized these clinical systems to the point where we all tend to forget this. And in terms of the metrics, again, one thing that I want to bring up, which is a current challenge, is a lot of the trials that happen. Very few, like the TB practical has QOL sub studies, it has quality of life sub studies, but very few trials actually measure quality of life. इसके दो कारण हैं. एक तो हमारे पास हम सेंट जॉर्ज टूल यूज़ करते हैं, जो लोग यूज़ कर रहे हैं, लेकिन वो लंबे समय के लिए एक्यूरेटली चीज़ें नहीं कैप्चर करता. So in terms of the tools, we do have a challenge. But at the same time, there's a need to measure these things holistically, not just looking at diagnosis, treatment, and then the follow-ups in terms of your blood work, whether your vision is fine. All of that is very important. But holistic quality, your social role functioning. Are you able to participate in daily life? To what extent? Your physical movement, your mental health, your emotional health. Are you happy? Um, and we need to figure out, if those tools don't exist right now, then some part of TB research needs to focus on developing those tools that allow us to measure in clinical trial settings and programmatic settings. But currently we fall short because we kind of eyeball it, where we're like, ठीक है दवाई ले ली, साइड इफेक्ट हो रहा है, उसको मैनेज कर रहे हैं, आदमी जिंदा है, okay. And a lot of us, including the people going through the treatment, also settle for that, कि जिंदा है ना, ठीक है. People don't even survive this. But we do need to go beyond that, both in the research space and in advocating for ourselves. Because, like I told you, the doctors I told you about, and I was very lucky that most of them were fantastic. But this can't rest on individuals' shoulders. This has to be systemized. So that's my response.
I mean, this is an interesting point. ये एक interesting point है, क्योंकि आप पेशेंट हैप्पीनेस, पेशेंट वेलबींग, क्वालिटी ऑफ केयर में ला रहे हैं. आप ये भी ला रहे हैं कि किस तरह की जो पहले बात हुई पोस्ट ट्रीटमेंट केयर की भी. बट जो हमारे हेल्थ सिस्टम की हालत है और जो हमारे उसमें रिस्ट्रेंट्स हैं, उसमें आर्ग्यूमेंट ये दिया जाएगा कि देखिए, हम पेशेंट को सही टाइम पे डायग्नोज कर ले, ट्रीट कर ले और उनको सही समय तक दवाई पे रखें. ये हमारा गोल है और ये हमारी अचीवमेंट भी है. That's our goal, really. I mean, look at the enormous burden of people we have. Now you're expecting health workers to handhold everyone. And that is where it becomes a little tricky, because tuberculosis is one of those diseases which has mental health consequences, which has social consequences, which has gender consequences. मगर हेल्थ सिस्टम के लोगों को तो इस बारे में प्रिपेयर नहीं किया जा रहा है, और ना ही वो necessarily with the current staffing structure and the current Sorry, I've been muted all along, I think, and I've been talking. Sorry, but I wanted to say that I don't know if what I said previously made sense. That with the current constraints, quality of care becomes like a difficult thing. We want our doctors to diagnose, treat, or I want to say the whole health system, but they are not equipped to address social factors, environmental factors, economic factors, or other such issues. And their argument is very simple कि हमारा बर्डन इतना ज़्यादा है कि अगर हम लोगों को सही समय पे पकड़ के दवाई खिला दें और उनको अडियरेंट रखें, which is a which from a patient and from a community perspective is slightly dehumanizing thing. मगर हम यही खत्म कर ले तो बहुत बड़ी बात हो जाती है. आप कह रहे हैं कि अब इनके नॉन क्लिनिकल फैक्टर्स में भी ध्यान दीजिए. So Jay, I wanted to ask you, how realistic is this, and how do you think doctors and health workers, and by doctors I mean both in the public and private sector, um, try and engage with some of these issues? कैसे क्या वो कर भी सकते हैं? Is it feasible?
Patients
Yeah,
and sorry.
yeah,
Yeah. Yeah, so you do tend to talk to patients about how they feel, or those kind of things. Especially, I think more importantly, looking at things which you can correct at your end, like say side effects or something like that. Somebody has early signs of neuropathy, you might want to get them off the linezolid, or if they get depression, you might want to get them off the cycloserine, etc. Counsel them through maybe what's happening to their skin color with clofazimine. As long as you're giving patient information and you're acting on their feedback, that's good. It is almost impossible for you to kind of, you don't have just one patient, you have multiple patients and multiple types of patients. So you cannot address every concern, which is why a separate system which takes care of some of the other sorts of non-medical things would be ideal, which might not always be available, like say nutrition or economics or etc., things like that, or even mental health support, etc. But even if we can manage to have even say a continuity of care where the same doctor or same team is in charge of the same patients, group of patients till their treatment is over, where they can develop kind of a personal bond where the patient is confident enough to get back to the doctor in case he or she has a problem. I think that would solve some of the problems, but I agree it's not possible to solve all the problems, whether in the private sector or in the public sector.
So let me ask you this, Jay. I think you've made a very valid point. What are the things that you think can be incorporated in the current health system? See, as people who are affected by the disease, people will always ask for more. But what do you think is actually feasible in terms of what can be done? You think in terms of reskilling our health workers a little bit or something? What are the issues you think that can get addressed?
So I think, as you said, if those who are allowed to prescribe TB medicines, as long as they are trained to, one is not only diagnose and treat, but to look at side effects, look at and give them instructions as to what has to be done when they are faced with a certain side effects, whether it is hepatitis due to TB drugs or any other side effect that they do encounter. What do they do with, as you said, with the sequelae of TB? Many of these patients could come about, end up with some kind of breathlessness, or weight loss, or or they are malnourished, or something like that. If you have extra pulmonary TB with organs outside the lung, like say meningitis, etc., are you involving the necessary specialists to co take care of the certain organs which you might not be an expert in. So as long as the doctors who do treat TB are sensitized to these things, that will probably go a long way towards improving the quality of care that we give the patients and the eventual outcomes that come about.
Thanks, Dave. I'm going to ask follow up on a question because I think your perspective is very important here, and then take that to Akshata also. But what about issues like building family care systems? Do you think those are things that the health system should be engaged in for TB patients and to be effective?
Family. So generally, we would like a responsible person from the family accompanying a patient who is ready to take some kind of responsibility to make sure that the patient gets his or her medicines, whether it is the mother or the wife or the daughter, son, whoever, and make sure the patient gets medicines, and the patient can, if the patient has a problem, can tell that person, and that person can contact the doctor, because not every patient will be able to contact the doctor. So I think that kind of family support is very important. And thankfully in India, we do have that in most cases, barring a few, uh, unless the patient is living alone, etc. That But those are rare instances. Most patients would have some kind of family support, which makes it a little bit easier for them, compared to, say, we know people abroad who very often live alone, or that kind of thing.
Thanks, Jay. Akshata, can I take the question to you now? Because Jay has outlined some of the things that can be done. But as a TB survivor and a TB advocate, what do you think are the non-negotiables in quality of care, the role of community in defining that quality of care, right? Because when we were developing this report, some of the things that came up is how is it that I don't have enough information? How is it that nobody's listening to my mental health issues? How is it that um, nutrition was something that came up. And every time we speak to the health system says, okay, really, we're not equipped to handle the nutrition issue. Maybe the mental health issue and the patient education and the information asymmetry issue is the what according to you are the important aspects of quality of care from a person who has survived TB, their perspective, and how do you think communities should be involved in defining this quality of care?
Um, I think, in my opinion, as Dr. Jay rightly mentioned, is that one person cannot take care of everything, and that is where I think segmentation really, really helps. And I think this is exactly so. I think the physical aspect of the disease is already being taken care of by our doctors, but when it comes to providing emotional support or social support, I think then that is the outer circle where your family comes in, where your friends come in, and then your peer support group also comes in. So I think that level of segmentation also would make me as a patient feel sorted ki, okay, this aspect of my physical health is being taken care of by an expert. If I need to talk to somebody about how I'm feeling right now, then I have my friends, I have my family. If not that, I have my peer support groups, because I'm able to see people who have been through the same and now are leading a healthier life. So that gives me sort of motivation to keep going. And maybe having that sort of information and awareness ki, okay, something like this exists. You can confide in people, you can go talk to people. There is a community where you can find TB survivors and talk to them about your issues. That can keep you sorted. And then I think after that comes your parallelly, I think these things go parallelly, is your mental health support, because in some cases, if you don't have issues, it might be triggered, or if you have issues, they might be escalated. So I think seeking support at right point of time and having that those different channels running parallelly would help me as a patient keep my anxiety under check. So I think that segmentation is very, very important, because putting everything on just one person is absolutely bizarre.
I see the point that you're making. Asha, I'm going to come back to you with this point, and I'm also going to go to Jay, because the obvious argument counter to it, I know what Akshata is saying, is that how many touch points should a patient have? And are our communities and families ready? And who will prepare them? Right? And mental health per se in TB, both with a previous history of mental health, but also current medicine induced mental health challenges, needs the guidance to some extent of um, a mental health practitioner. Can we leave it just to families? That is also, see, the families can keep you motivated, they can keep you engaged, they will not let you fall off treatment. But does that necessarily solve that problem? I'm just wondering, what do you think?
So, thank you to Dr. Jay and Akshata for the incredible comments. I'm just going to build on that in terms of whether this solves the problem or not. I think, and I'm going to go back to your non negotiable question as well. The first non negotiable is treating the patient as a co-producer of care, not as passive recipient, right? And from my personal experience, and even in my work, I've seen this that when you do that, and this is also in some ways what Dr. Jay was mentioning, that when there's that trust, when there's that partnership, the patient will come to the doctor with feedback. It is not humanly possible for one doctor to keep track of what's happening to every patient. It is not humanly possible for the patient also to, beyond a point, have certain touch points. But once you create that model where a patient is a partner in the care delivery, there is a lot more sort of confidence also that comes in terms of, okay, these are my needs, this is where I'm facing challenges. And to a certain extent, when that autonomy is respected and it's given, because you can't give someone the autonomy, but when it's given that enabling environment, a lot of these things get taken care of. Um, then you also have to factor in things like privilege and access, of course. So when I say that when I was facing mental health issues, my doctor told me that this is a side effect of the medication and that I should get in touch with a therapist or a psychiatrist, I could afford one, right? But it's not the case that everyone will be able to. So even in limited constraint settings, we're going to have to find ways where the non-negotiables at least being that, one, there should be some form of basic psychosocial support, where there is, when you're, this could be integrated into primary healthcare settings so that you're not putting too much burden on any one particular group. And in any case, TB patients tend to have to go for basic follow-ups or get basic follow-up tests done. So this one thing, and particularly with technology now, I mean, you could literally have it on someone's WhatsApp where they tell you how they're feeling in terms of a survey or whatever else with different modalities. But those basic checkpoints need to exist. And from there, then once a patient knows, okay, this is what my needs are, then working with their care provider to understand what would, or their families or whatever support system they have in place to understand, where do I go with this. But very often that piece is missing because everyone is telling the patient what to do. And like I said, we have great individuals who take the time to give, patients' concerns value, to treat them as partners. But this cannot rest on individuals. Doctors, nurses cannot be expected to pick up this mantle on their own. The system has to be built in such a way. So my first non-negotiable would be shared decision making in care, because that would take care of a lot of these things, and that is possible in any resource setting, whether you're low income, low middle income, high income. Shared decision making and trust is accessible everywhere. So I would start there.
I think that's an interesting set of points, and I think we do have some non-negotiables clearly from the patient point of view and from people who are affected. My question would be to if these non-negotiables can actually be, while if you were to look at mental health, patient education, nutritional support, I'm just throwing a couple of things that have come up in our research. Uh, Things like family engagement and sensitization, which also leads to stigma reduction. Is that even conceivable, Dr. Jay? Is that conceivable in a system of care that we could develop?
Using family involvement or
No, I mentioned four or five things. I said mental health support of some kind, nutritional
yeah.
support of some kind, some gender responsiveness and sensitivity. Although I think most health workers are sensitive to the fact that and using the
What
family as a way
your, your,
to
your voice is cutting, so I mean I couldn't get the whole
sorry,
question. Yeah.
using the family as a way to reduce stigma, but also provide continued support.
So I think yeah, using the family definitely. I mean, getting the family or family and close friends involved is a big step. Second, nutrition support. I think that is feasible. I know patients who are admitted for TB are given extra nutrition and etc. At least in the public hospitals that I know, you would they would get their extra eggs or etc. Higher protein diet. So I mean, it should be possible. We had the ration study done in for TB patients and contacts in Jharkhand. So if it has to be on a larger scale, it has to be implemented throughout the country. It shouldn't be very difficult or very expensive. Whether how you do it, whether that is through cash like the BMC is doing, giving I think 500 rupees a month to patients, or whether it is through food coupons or etc. I mean, those modalities can be worked out. Gender, that is, I think it's more a societal issue where I think healthcare workers and general uh, family members, etc., everybody has to be sensitized and educated about this. About that the equal rights of healthcare between men and women. So I mean, it will probably not happen overnight, but I think these steps can be taken. I don't think it's something which should look away from.
Sure, I think those are valid points. I wanted to start with Akshata and ask each of you, because I think we're closer to finishing 45 minutes, and I would ideally like all of you to give your non negotiables also. Um, there's actually two sets of questions. The first one is if there is an and each one of you has a different perspective on this. Each of you have a different area कुछ और सोच हो सकती है. If there is one thing that you would change within the health system, जो आपका interaction था over TV, uh, what would it be? And I'm going to follow it up with another question. But first, Akshata, let me start with you. What would it be अगर आपने एक चीज बदलनी होती तो?
Because we're talking about my care, my metrics, I think my non-negotiable would be, as in what I would expect is speaking with care and speaking as if you care as well. Because I think, as Ashna said, it's a partnership, right? It's not the person should not person as in my caregiver or the person who is treating me should not make me feel as if I'm alone in this, and only then will I be able to confide ki, how am I feeling right now, and will be confident enough to share my problems. So that's A. And having said that, I think this calls for an empathetic ear, because I think we as patients, while going through that, know something might not be done right here, right now. But at that point of time, we just need an empathetic ear who can probably just listen to us and not invalidate as to how we are feeling. So I think these are my two non-negotiables. You asked for one, but I'm giving two.
No, no, more the merrier, the better. Jay, I'm going to turn to you. You have an outstanding trying to understand how care can be bettered. So
I
if
think
you
you
had,
are offline or something. Could you repeat it?
yeah, sure. What would be one thing or a couple of things that you would change in the way TB care is delivered currently, as you see it? Because you see it obviously from the perspective of care and a clinician, but also you see the gaps more clearly.
One is, if one is, of course, access is, I think, the most important thing. I mean, everything else will, be secondary if they don't have access. So access to diagnostics and treatment is probably the most important thing still, despite everything else. Second, as I said, if we can have some form of continuity where, the same, I think that goes a big way, and which where I think that's where the private sector probably does a little better, is if you have the same doctor looking after the same patient throughout the course of treatment, rather than him needing to jump between doctors, one between follow up to follow up. I think that keeps a more personal equation between the doctor and the patient, and also builds trust. I think if that happens even in the public sector, I don't know how much it probably does, but if that can be ensured, I think that will go a long way.
I think that's an interesting set of things. Ashna, let me come to you because you were treated in the public sector, and there is this very important point of patients with one doctor is patient एक doctor, which is very important, and also कि बार बार अलग जने के पास नहीं जाना. uh, that is one thing. जो आप trust building की बात करेंगे, that is crucial, and that cannot happen in with like multiple parties involved. It has to happen with a single with a certain relationship that you build over time. That bond has to be there. दूसरी बात ये है कि what would be your non-negotiables? Because Jay has spoken from the private sector, Akshata has spoken from the private sector, but you are from the public sector, and you had a good doctor in the public sector, but you also saw the gaps around you.
Yeah. So my doctor actually initially was in the private sector. I just followed my doctor around wherever he went because मुझे इतना trust था कि I was like आप जहाँ भी जाएं मुझे आप ही से treatment कराना है. So that's how I ended up in the public sector towards the second half because he was in the public sector after the private sector. But definitely two things that I would say are non-negotiables. And well, initially when I had my lymph nodes swollen and I went for my FNEs, that experience where I didn't get a DST, where I kept telling my doctor that, look, I'm not feeling too well and I'm somebody who can cope with like multiple things. So when I'm telling him my capacity, it's not a regular interaction to TB meds, I'm not doing well. But it took me a while to say this to him. So one of the things that I want to say is for patients, which is a non-negotiable कि इलाज में और मेडिकल साइंसेज में डॉक्टर्स एक्सपर्ट्स हैं और अपने खुद के एक्सपीरियंस में कि आपके साथ क्या हो रहा है इस पे आप एक्सपर्ट हैं. आप जितना इन्फॉर्मेशन डॉक्टर को दे पाएंगे एट द एंड ऑफ द डे, two things will happen. One, it's a great doctor, you will get the kind of care you need. Two, you will get a signal that you need to go elsewhere, which is what I finally got. But I waited too long because I didn't trust my judgment. So one is that building patient awareness and capacity to the point where trust yourself when you think something is off and advocate for yourself. The second is for the system, which is you need to treat lived experience like data. Like you track SGPT elevated है कि नहीं है, किडनी फंक्शन कैसा चल रहा है, ऑडियोमेट्री टेस्ट कराते हैं, आप आंखों का टेस्ट कराते हैं. ये सारे टेस्ट होते हैं हमारे जब हम टीबी की दवाइयाँ ले रहे होते हैं बिकॉज उनके बहुत सारे साइड इफेक्ट्स होते हैं. उसके साथ साथ लिव्ड एक्सपीरियंस इज जस्ट एज वैलिड एंड क्रूशियल एज डेटा. आप उसके साथ वो पेशेंट की प्रॉब्लम सॉल्व कर पाए या नहीं, दैट इज सेकेंडरी. When you know there's a problem, you can refer them somewhere. For instance, with me, for the longest time, what happened is, despite me being on a very protein-rich diet, my weight was not budging from 45 kgs for about a year. I had extra pulmonary TB. Weight was one of my drivers. और मेरा weight बढ़ नहीं रहा था. So in that public hospital, what my doctor did was he referred me to a nutritionist who helped me optimize my diet. Right? He let me sort of run with this for a bit, and then he's like, now we're going to bring in someone else. उन्होंने खुद नहीं किया बैठ के. But he heard my problem long enough to understand that okay, even with a high protein diet, अगर किसी का weight 45 से टस से मस नहीं हो रहा, we have a problem for about like almost a year. So those two things need to happen. One, we empower patients to be able to advocate for themselves, and two, when this lived experience is offered, it needs to be treated as data, because it is data and it's very crucial. I mean, that's why patient history is still treated as a cornerstone of medicine, because आप patient से जितनी बात करेंगे आपको उतने अच्छे से पता चलेगा कि actually problem क्या है, not just the illness, but because illnesses don't exist in a vacuum. Thank you.
Yes, I know what you're saying because देखो कई साल पहले we had recommended a young boy with XTR-TB to Hinduja, and all his tests came out negative after long treatment, and he kept saying कि मुझे कुछ हो रहा है, मुझे कुछ हो रहा है. I'm quite certain TB वापस आ गया है. And then the doctor and the psychiatrist, actually the doctor who was a very seasoned doctor, told me कि देखो ये अब we've looked at all the tests और हम सारे टेस्ट दो बारी कर चुके हैं. This child has no problem, but what he has is a mental health and anxiety issue, and you need to send him to a psychiatrist and not to us anymore, because what he has determined is that his TB will come back because his TB had come back earlier. So we could not have guessed because the patient was very sincere and very sure. So we got their tests done first at Medanta and then at Hinduja, and both the doctors turned to us and said, "This is not a TB issue anymore. This is a mental health issue, and we need a different kind of treatment. We can recommend them to other people." So I think that is also interesting. I just want to take the last point to Jay, because I think Ashna did want me to ask a couple of questions also. Um, this question about looking at what the patient tells you and working with it. अब ये बहुत से डॉक्टर्स हमें ये भी कहते हैं कि पेशेंट को इतना सब कुछ इन्फॉर्मेशन देते हैं, अगर हम सब कुछ करने पड़े तो उनको पता नहीं कितना दवाई देना पड़ेगा. तो where's the balance in trying to achieve a good quality of care, listening to the patient, and also keeping it real in the health system? Because that is a tricky thing that you have to manage, right?
No, everything may not need medicines. I think that's the most important thing. Sometimes you just might just have to listen to them and reassure them that okay, this is important, this is not so important, this is something that you will just grow through, or it'll go away, don't worry. So there are certain things which once you listen to the patient, then you know what is likely to be critical, and what is not critical, and which you can maybe just counsel the patient and tell them, okay, this is nothing to worry about, don't worry. And if something needs treatment, of course you advise treatment. You don't have to give a pill for every complaint that the patient does give you. So but as long as you're ready to listen, that's when you know what to treat and what you need to maybe just assuage the patient and tell them that it's okay, don't worry.
I think that sort of looks at our discussion in a holistic way, because there are three immediate perspectives we are seeing from Akshata and from Ashna, which are very survival-led, patient-led, which look at and these are very important because they reflect in many ways the lived experience. जो survivor या patient है उसकी real life problems क्या है, it tells us about that, जो कि सिर्फ diagnosis और treatment से थोड़ा सा हटके है. और वो मगर हम ये नहीं समझते, we don't realize that they influence diagnosis and treatment. It influences your ability to seek a diagnosis and access it. It also influences your ability to finish your medication and also eat something. Move on with life. And also the question of managing the clinical side of things, which is really about diagnosing at the right time and treating the right way, and trying to manage the side effects in the best way possible. I want to open this to last comments to everyone. Jay, I'm going to give you the chance to give any last comments if you want to, because I know you're waiting to go home from your office.
No, as I said, quality of care would, we know one size doesn't fit all, but there has to be some level of standard thing, a minimum standard that has to be maintained for a certain disease that we need to ensure and expect that a doctor would in his prescription or in his treatment would adhere to that. Of course, rapid diagnosis, early access to treatment, and a continued access to treatment is important. uh, and involving maybe all patients might, I know, as we talked about how many touch points should a patient have, but every patient will not need all the touch points. So as long as we have touch points that are available and the patient can then pick and choose what they need, that should be good enough. You don't need to have every patient visiting a counselor or a nutritionist. You could have some person who needs a nutritionist, you could have some people needing a counselor, and you might need a few who need both and a few who need none. So it would be a kind of, it's like a jigsaw puzzle where you have to see what fits best for that individual patient. So you don't have everybody need to go through five people. Some people might need five people, some people might be able to do with one. So as long as the availability is there, that should be good enough.
I think that's a very valid point. As long as the availability is there and differentiated and individualized care is available to some extent. Of course, in a low income and medium income country with limited health budgets, this is never going to be entirely possible like we imagine it. But there are restrictions and those need to be addressed. I wanted to raise one point which I think is my fault we've missed, is that with the growth of technology, when use of AI in diagnosis and other methodologies, the option of having more and more support is available, and we have to explore that, because a lot of the work that was being done by individuals will leave their hands and can actually be used, does leave the individuals free to actually engage in providing differentiated services to people in the health system. Akshata, what about you? I want to give you a chance of making any closing points if you want to.
I think, firstly, from a very patient perspective, or from a lived experience perspective, I would just like to say that, as Ashna rightly mentioned, we should be empowered enough to feel that, okay, whatever I'm feeling, it's not nothing. Firstly, we should be able to validate what we are feeling. Only then we'll be empowered to ask the right kind of questions. And having said that, from a system point of view, I would just like to say that. Listening, having that listening empathetic ear would go a very, 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 very long way. So I think, these are my, what do you say? Yeah. This would, for me, would sum up the discussion, wherein I would like to say my care, my metrics. This is what sums it up for me.
Yeah, I think that's a very valid point, because a lot of patients and actually a lot of families turn around and say, we just want to be heard and understood. We know some of these issues cannot be solved necessarily in the health system,
Yeah.
but
So just to add
we
on to that,
want.
I'm so sorry because it
Mm.
just
Yeah,
clicks
yeah,
with me.
please.
Because I remember, when I launched my book, because it's a documentation of the journey that I've been through. I really, really wanted to have people who are currently going through the disease. So I had invited a couple of them, and after the ceremony was over, one boy, I did not even know him, Kritika. He was Kritika's friend, who's a SATB fellow as well. Kritika had gotten him along, and once the ceremony was over, he just asked me, Akshata, I can talk to you for a second. I was like, yeah, please go ahead. So he was like, Akshata, it's so good to see that your family validates your disease. That they are actually validating what you're feeling, because in my case, even at my home, my disease is not being validated. They just don't feel okay, what I'm going through is worthy of speaking or worthy of bringing it up. So I think that, since we're talking about listening, I think, and validation, I think it starts right from your home as well. So yeah.
Yeah, I think that's also a very valid point, because the one thing we have not touched upon extensively is stigma and stigma free care. And the point, of course, is that stigma doesn't manifest in just the way that we think it manifests, in which is the doctor saying to you, "Mere paas mat aao, हमें treat नहीं करना तुम्हें," which happens very rarely. Actually, it most often happens within families and communities, where the family turns around and says, पता नहीं कैसे हो गई या the community says तुमने कुछ गलत ही किया होगा. You know, the common notion is you smoke, you have some kind of lifestyle that you can. How did you get to be and nobody else? Which is also victimizing and blaming, and also kind of I don't want to use the word, but witch hunting. It's as if your disease chose you, which is a bizarre thing. But it happens all the time. So stigma is something we haven't discussed. But Ashna, I want to turn to you and ask you what would be your closing point.
Thank you, Chapal. I think for me, the closing point would very simply be the means are the ends. If the and I think this framework, the fact that we're having this discussion, we're talking about quality of care. Survivors are involved in articulating what it is that it means to them. We're already seeing that shift coming in, and the fact that survivors and caregivers are working together to sort of define this. If we want person-centered care, if that's the end goal, then the design of that also has to involve the people that are going to be at the receiving end of that care. And that would be a non-negotiable for me. And that sort of involvement in care design, policy design, or even at a very individual level, when I'm sitting with my doctor, you know, we don't have time to spend 30 minutes per patient, of course, but it's little things like just listening कि अच्छा आज आप कैसे हैं. अगर आप you're repeatedly seeing कि patient बार-बार आपसे बोल रहे हैं कि नहीं ठीक नहीं लग रहा, तो maybe a couple of follow-up questions a week, couple of weeks down the line, maybe see if you need to refer them somewhere else. तो ये छोटी-छोटी चीज़ों से जाके ही फिर वो, if your end goal is a patient who's able to live well, then during the treatment, during the diagnosis also, we have to do whatever we can ourselves as patients and as care providers or public health advocates or public health professionals to make sure they're able to live well. They won't magically live well one day after the treatment is finished. So, yeah, the means are the ends. And as far as stigma goes, I think the messaging that we have we seem to keep, we need to learn from COVID here, which is initially when COVID came about, there was a lot of stigma initially. देन पीपल क्विकली रियलाइज कि किसी को भी हो सकता है. टीबी में वो सोच अभी तक प्रिडोमिनेंटली आई नहीं है. लोगों को समझ नहीं आता कि अगर आप सांस लेते हैं तो आपको हो सकता है.
I think those are all very valid points. एक तो स्टिग्मा की बात की आपने, जिसकी हम पहले भी बातचीत करें. Stigma becomes crucial in high quality care. But I think the fact that jumps out at me is that between a resource limited health system and a very large patient load, we have to make improving quality of care an incremental process. कि हर कुछ प्रोसेस महीने में कोई प्रोसेस चेंज हो और इम्प्रूव हो. It has the movement towards quality or high quality, so to speak, has to be a distinct and ongoing process. It has to be something that is almost divorced from the health system and looked at from outside by experts and said, कि यहाँ क्या gap है? You know, it's almost like the way that McKinsey consultants come sometime and look at a process and say, why is this process failing? And the reason I'm not inviting McKinsey consultants. I think between the health system, we are all competent to do that. But my goal in saying that is कि जब तक कोई इसको regularly examine करके इसको improve ना करे, I mean, 10, 15 years ago when we used to talk about stigma, people in the health system used to say, अरे दवाई तो दे नहीं पा रहे आप, पता नहीं कहाँ से stigma उठा के ले आते हैं, ये कहाँ से हम deal करेंगे? You added another layer of complexity to our lives. What is this stupidity? So, I mean, now of course we do stigma trainings and stigma-free care is a cornerstone of the national program, but also in the private sector. But these are things that one has to keep moving towards, because I don't think quality of care can be achieved within a year, or high quality care can be achieved within a year, that we just change the processes. Also, we have to remember that the processes that have been in place work for some people for some extent. Whether they work for the patient or not is another matter. That is something we have to ask patients also. We have to ask community members also. भाई तुम्हारे लिए ये process चल रहा है ठीक से कि नहीं? Because otherwise, if we are failing the patient, then we might be defeating the purpose of providing inequality of care, high, low, or medium, that doesn't matter, I think. So that those would be my final words. First of all, thank you so much, all three of you for joining me. It's a very interesting discussion, and we hope to continue this discussion forward both through this framework, but also through the questions and the other things that have come up to us today. We've run out of time, otherwise I would have taken some of them, but I think we can answer them going forward on our own. So thank you so much, Dr. Jay, Akshata, and of course Ashna. Always a pleasure to speak to all of you.
Thank you so much.
Thank you. We'll see you for our next discussion soon. Take care.
Bye bye. Thank you.